So historically, patients with myelodysplastic syndromes and high-risk disease can be cured with an allogeneic hematopoietic cell transplant. In cases where patients have a high percentage of blasts or they progress into secondary acute myeloid leukemia, therapy is needed to try to reduce the blast percentage before they can go to transplant to improve the transplant outcomes. So typically we use medicines called decitabine or azacitidine, which are hypomethylating agents to try to reduce the blast percentage, but about half of patients will be refractory or relapse before they can get to transplant. And in those patients, second lines of therapy are very limited with an average overall survival of about 6 months. So it's very important to develop new treatments to help get those patients to transplant and optimally to get a cure. So in this study, we developed a novel cellular therapy that's intended to try to reduce the blast percentage and get patients to transplant. What we did is that we got mismatched unrelated donors, donated their cells, and then we do what's called a CD8 depletion to remove CD8 positive T cells, because those are cells that our preclinical data showed can cause graft-versus-host disease. So the remaining cells are primarily CD4 positive T cells, and those T cells, the CD4 T cells, are helper cells. So when they go into the recipient, they provide immunologic help that helps to activate the recipient's immune system so that the recipient's immune system can attack the tumor. So basically, we're stimulating a host versus tumor response by giving them unrelated donor CD4 T cells. The other thing that's very important about this is that the HLA mismatch is intentional because that better activates the CD4 positive T cells so that the attack against the tumor is more potent. So in this study, we did a phase 1 trial using standard induction chemotherapy that's used normally for AML, combined with this CD8-depleted donor lymphocyte infusion. And we did a dose escalation with 3 dose levels. And we saw no dose-limiting toxicities at any of the dose levels. So the highest dose level, which is 5 × 10⁷ CD4 T cells per kilogram, was chosen as the optimal dose. In terms of other toxicities, we did see 1 patient at the highest dose level that had grade 2 cytokine release syndrome. And notably, we didn't have any patients develop graft-versus-host disease, despite that this was an HLA mismatched product. In terms of efficacy, while it's premature to really evaluate based on such a small number of patients, it's only 9 patients at this time, we did see a dose-dependent improvement in response rates. So at the first dose level, we had, or at the lowest dose level, we had no complete remissions. At dose level 2, 1 of the 3 patients achieved a complete remission and went to transplant. And at dose level 3, 2 of the 3 patients achieved a complete remission. Both of those patients ultimately did go to transplant. The other thing that's really important with this is that these cells do not engraft. So we did DNA studies where we followed the patients over time and found that donor DNA was not present after the treatment was complete. So it tells us that these cells are going in, activating the immune system against the tumor, the patients get into remission, and then the cells disappear. And then ultimately, the patients do proceed to an allogeneic transplant that is hopefully the long-term cure. So we are now enrolling patients in the expansion cohort at the Moffitt Cancer Center, so we're enrolling 10 additional patients at the highest dose level. But we're very excited about this because the response rates we're seeing appear so far to be favorable to historic, which is about 20 to 30% in comparable patients. And at this highest dose level, again, it was 2 out of 3. So if we maintain that type of response, it'll be a big change in the treatment paradigm, I hope.